All right, so what we're doing, right, is talking about endometriosis and its impact on fertility. We'll talk about surgical treatment and the benefits of surgical treatment and how important it is to diagnose endometriosis early and to treat it appropriately. All right, so what is endometriosis? So a lot of you probably know a little bit about it, but essentially what it is when abnormal tissue that should just grow inside the uterus starts growing outside of the uterus, and that causes inflammation and pain. This is a little bit of just kind of a quick anatomy lesson. So this is a cross section. So if you kind of stand sideways, right, and then we're cutting across to see inside. So you have intestines, then you have uterus here, and then there's bladder that sits in front of the uterus. There's your rectum sits behind the uterus, and you know your back, your spine is here. So when you think of symptoms, think of anatomy, right? So if endometriosis most commonly grows in the pelvis, so when it grows outside of the uterus, most common locations are going to be somewhere near the uterus. So behind the uterus, you have rectum. So bowel symptoms are very common. Someone asked in the Q&A section, can pain from large intestines be related to endometriosis? And the answer is yes. Can pain from endometriosis be related to bladder symptoms? Yes. Can you have lower back pain? Yes. Right. So you can have all of these symptoms that sort of mimic irritable bowel syndrome or mimic overactive bladder, but it really is caused by endometriosis. In women with pain, infertility, or both, the frequency of endometriosis is 35 to 50%. So that's actually really important because, you know, a lot of times we see posts online that says 1 in 10 women or 1 in 9 women have endometriosis. But that's just of all women, right? Symptomatic and not symptomatic. But in someone who has pain or infertility or both, up to 50% of those patients will have endometriosis. So this is a very high number. The symptoms, you know, in addition to the bowel and the bladder and the symptoms from the surrounding structures, endometriosis causes, you know, menstrual symptoms. So menstrual pain, right? Uterine pain, as I mentioned, lower abdomen, lower back, pelvic area. Pain with intercourse is very common. And then sometimes it can cause abnormal bleeding. In up to 50% of patients with endometriosis, they will have infertility, and so inability to get pregnant, but also higher miscarriage rates. So they might get pregnant, but have a pregnancy loss. But 25% of patients won't have any symptoms, right? So no symptoms despite having endometriosis. So their only symptom might be infertility. There are different stages of endometriosis, and, you know, patients like to ask, you know, what stage am I, 1 or 2? It's the main thing to remember is that do you have mild endometriosis or severe? I think it's easier to just think of it that way. So stage typically 1 and 2 is mild, stage 3 and 4 is severe, because your sort of prognosis in terms of pregnancy, your treatment is going to be different depending on whether you have mild endometriosis or severe endometriosis. But the stage can only be determined through laparoscopy, right? So how extensive, how severe endometriosis is, we would only know if we actually looked inside. The symptoms themselves can give us some idea, but it's not always reliable. So if I have a patient who tells me that she's not able to have bowel movements without laxatives at all, right? And she has severe pain with menstrual cycle, that makes me concerned that there may be endometriosis that's so extensive that it's actually growing into the rectum and blocking the rectum. But that would be very rare, right? Common cause of constipation is diet induced. So again, we kind of look for these signs in the symptoms, but at the same time, laparoscopy is really going to be what's going to let us know how severe endometriosis is and what the treatment should be. Endometriosis is a common cause of unexplained infertility. So what is unexplained infertility? So let's say you've been trying to get pregnant for a year or more, and you go see fertility doctor, and these are specialists that specialize in treating patients who have trouble getting pregnant, or who need help getting pregnant. And they do all the tests. They do the blood work to check for hormone levels. They do semen analysis. They check the fallopian tubes. They make sure that the anatomy, that there's the uterus and there's ovaries and tubes, so that everything looks and appears to be functioning normally, but for some reason you cannot get pregnant. So that's called unexplained infertility. So most causes of unexplained infertility is actually endometriosis, right? But again, without laparoscopy, you don't know that. 25 to 50% of infertile women have endometriosis, and then 30 to 50% of women with endometriosis are infertile, okay? Infertile women are 6 to 8 times more likely to have endometriosis. Severe endometriosis significantly lowers the rate of pregnancy and live birth, even with fertility treatment. So it's important to remember that just because you go through fertility treatments and do IVF, that does not guarantee that you will get pregnant, and your success rate is going to be significantly reduced with severe endometriosis, but you wouldn't know that, again, without laparoscopy. Now, how does endometriosis actually affect fertility? So it can affect fertility in many different ways. So here's the little anatomy picture. You have the ovary here, and so ovary already has eggs in it, all right? So they're there from the very beginning. And every month, a little egg, a little follicle rather, with what we call immature egg matures, and then one mature follicle releases an egg, so that's called ovulation. In order for ovulation to happen, there has to be correct hormones released at the right time, the right amount of hormone. So actually, endometriosis can affect hormone levels, okay? So it can even affect ovulation. Now, when the egg leaves the ovary, it has to be picked up by the fallopian tube. So inflammation from endometriosis can affect the ability of the tube to pick up the egg, because there's too much sort of irritation, again, inflammation in the surrounding structure. It can also block the fallopian tube, right? So here, and this actually a real picture from surgery, this is stage 4 endometriosis with everything being completely sort of distorted. This is ovary, this is uterus, this is fallopian tube, and the fallopian tube and the ovary completely stuck. So nothing's going to be happening here. The egg is not going to be traveling up this tube at all because of the scar tissue and the inflammation. And then further, now you may ask and say, okay, fine, I'm gonna do IVF anyways, right? I'm having in vitro fertilization, so I don't need to ovulate. The egg doesn't need to travel. It doesn't need to meet with the sperm, because with IVF, all of that is done externally, and then the actual embryo is already placed into the uterus. But what you need to realize that it can actually affect the uterine lining and prevent implantation. So even if you're doing IVF, if you have endometriosis, that can prevent implantation. And that's how endometriosis can reduce fertility rates, even in patients who are going through fertility treatments. Now, a separate sort of category here is endometriosis cyst or endometrioma. So these can actually be seen on imaging, right? Because typically endometriosis, because the implants or the little spots of endometriosis are very small, when you do an ultrasound or a CAT scan or an MRI, any imaging that you might have, typically everything comes back normal. And that's one of the reasons that diagnosis of endometriosis gets delayed, right? So someone who has a lot of pain and sort of classic symptoms, they keep going from specialist to specialist, and they tell them, well, we did your ultrasound, everything looks normal. Maybe it's just your period, but of course we know that that's probably endometriosis. But in the case of endometriosis cysts, these actually can be seen on imaging. So a typical presentation would be someone who's starts having a lot of pain. So it's just progressively worsening pain. A lot of times the pain will be more constant, not just with periods, or maybe it will be worse with periods, but still the pain is there most of the month. And then on ultrasound, the cyst is seen as complex ovarian cyst. And typically, majority of the time, the ultrasound report will say, possible endometrioma. So these increase in size over time. And so what I frequently see is when patients come to me for surgery is that they've had, 2 or 3 or 4 or more ultrasounds just sort of following the increase in size. And that, definitely leads to delay in care. As endometriomas grow, you end up with less and less ovarian tissue. So think of it as endometrioma starting inside the ovary. So if this is the ovary, endometrioma is inside, and as the endometrioma grows, the ovary becomes smaller and thinner, and it's just kind of a sliver of normal ovarian tissue around the endometrioma. So at that point, when you remove endometrioma, whatever ovarian tissue remaining is what you have. The ovary is not going to grow back. So the sooner you take care of the endometrioma, the better. When it's addressed surgically, it is not supposed to just be drained. It's something that I see over and over again. Again, patients coming in for surgery and they have had prior laparoscopy where all the doctor did was they went in, they poked a hole in the endometrioma, they sucked out the fluid, and then you're done. So you can't treat endometriomas this way because that hole will seal up, and then the endometrioma will fill up with fluid again. So it's the cyst wall, the wall of the cyst produces this abnormal tissue and creates this fluid. So if you just drain it, it'll fill back up. And that's a sort of classic presentation when somebody says, I had laparoscopy, they couldn't remove the cyst, they just drained it, and now 3 months later, it's back again. And this is why you need a surgical specialist to address the endometriomas, because it needs to be properly removed. Another thing is that if you are someone who is interested in fertility, the key to removing endometrioma cysts is that you want to preserve as much as possible of the normal ovarian tissue. Of course, if there's been so much delay in care that you have a 15 centimeter endometrioma, there's probably not much there that can be done. You could preserve some of the ovary, but it's so small, it's just insignificant. But if you're at a point where, let's say you have a 5 or 6 or an 8 centimeter endometrioma, you want a specialist to carefully peel off or dissect the endometrioma off the normal ovarian tissue, preserve as much of the normal ovarian tissue as possible. Also to not use cautery on the ovary. So cautery is any device that burns tissue. So it's used to obtain hemostasis or to stop the bleeding. But when you burn ovarian tissue, you're also destroying the little tiny follicles that have eggs in them, right? And they're microscopic, so you can't see, you can see a bigger developing follicle, but you can't see the really, really tiny ones. So the goal of the surgery, not only to completely remove the endometrioma cyst wall, but also to preserve as much of the ovary as possible without using cautery. And that is the reason to use a surgical specialist. This is just a picture of the ovary with endometriomas in it. So here's one endometrioma, here's another endometrioma, and there's a little bit of endometriosis on the outside. So we would cut into the ovary, peel out the endometrioma cyst, and then either stitch back the ovary or just leave it and it'll heal by itself depending on the size. Adenomyosis, it's almost like a completely separate condition, but I just want to mention it. It's endometriosis of the muscle of the uterus. It can be, very focal, so in one area, right, or very diffuse where you have it all throughout the uterus. Or it can even be what's called adenomyoma. It almost looks like a fibroid, and these can be mistaken on imaging for a fibroid, either on ultrasound or even on MRI. But typically, we get an MRI to look for adenomyosis. If it's very tiny and focal, it may not be picked up on the MRI, but typically when it's diffuse, it's pretty obvious. It should always be suspected in a patient who has very heavy bleeding and a lot of pain. Patients typically compare it to labor pains. It is more common in women who've had pregnancies, especially C-sections, but we also see it in patients with infertility. So in a patient who has multiple failed IVF cycles, this is definitely something that should be suspected. And although it cannot be effectively removed because it's part of the uterine tissue. So if you start removing, for example, in here, you would have to take out the entire uterus. In this location, this picture is not entirely accurate because the adenomyosis starts out from the lining. So you would have to sort of take a block out of the uterus, which would, make it less functional. But patients should still undergo laparoscopy because remember, they can still have endometriosis outside. All right, how is endometriosis diagnosed? So the best way, as I mentioned, laparoscopy, right? So we make incisions. In our practice, we use 2 small incisions. We call it dual port. So 1 incision at the belly button, 1 in the bikini line. And we insert a camera through the belly button incision to look inside, and then use an instrument, little scissors, through the bikini incision to cut out the endometriosis. Ultrasound or MRI can diagnose the cyst and adenomyosis, but cannot see little tiny implants. So if you are someone who has symptoms of endometriosis, but who has normal imaging, you really need the laparoscopy to diagnose it and to treat it at the same time. And these are the 2 incisions after the ports have been removed. All right, what's the best technique? Patients always ask, do you do excision? Yes, the excision is the best way to remove the lesions. This is a picture giving an example of excision where we actually cut out the abnormal area and then strip that shiny lining, which we call peritoneum, versus burning. So the burning will work for little tiny superficial lesions, but it doesn't work as well for thicker lesions because when you burn, you're not actually destroying it, the entire thickness, so you're leaving kind of the base of it there, and then the recurrence is going to be higher. The key to surgery is to use a specialist, not a general OBGYN. So as I mentioned with the endometrioma, same applies if you have endometriosis implants. You really need a specialist because, first of all, you don't know, right, how advanced or how mild your endometriosis is going to be. When we do laparoscopy, right? So if you have very mild endometriosis, and let's say there's only 1 tiny implant, can an OBGYN remove that implant? Yes, or 2 or 3 tiny implants. But if you have endometriosis on or near the bowel, on the bladder, near the ureters, this is where the specialist is really going to be important. And because, again, prior to laparoscopy, you have no way of knowing how severe or mild your endometriosis is, you should always have a specialist do the surgery so that you don't end up having the laparoscopy, then realizing your endometriosis is too severe, and then having to have a second surgery by a specialist to now address what the general OBGYN could not. All right. The risks are lower when you have a specialist do the surgery, and that's true with any surgery. So, this is a high volume specialist, right? Someone who does surgeries all the time rather than someone who does surgery occasionally. The higher the volume of the surgeon, the lower the complications, because they, think of it just like with any sport or playing an instrument, right? If you practice all the time, you become better at it. Also, how to avoid complications, and a lot of times how to fix the complication or handle the complication. And then, if you're doing this for fertility, right, the more endometriosis you can remove at the time of the surgery, that will improve your fertility outcome, right? If you can preserve that ovary or more of the ovarian tissue, oopsie, what happened? Am I still sharing?
No.
No.
And we
Oh,
lost it for a bit. You can
okay.
pull it up again.
Let's see. That was weird. Oh, here it is. All right. Yeah. So if you can have a specialist do resection of your endometrioma, right, and you're able to preserve more of the ovary, that's again going to translate into improved fertility. All right. So benefits of laparoscopy. Accurate diagnosis of endometriosis and determination of severity. So again, if you have pain, if you have all the symptoms of endometriosis, or maybe just some of the symptoms, or maybe all you have is infertility, because again, remember 25% of patients don't have any symptoms. It's very important to do the laparoscopy, right? To make the right diagnosis and to figure out how severe or mild it is, because that's going to affect your management. You're going to remove endometriosis during laparoscopy, right? If remove that endometriosis cyst and not only improve fertility, but also improve your pain, right? Because, a lot of patients with endometriosis have a lot of pain, and maybe fertility concerns are a secondary issue. Maybe they're really suffering. And then again, you're going to determine appropriate treatment, including fertility planning. So with mild endometriosis, removing endometriosis will increase spontaneous pregnancy rates significantly. With stage 3 or 4, with severe endometriosis, a lot of these patients will need to move forward with fertility treatments, but removing endometriosis first will actually improve, again, their pregnancy rate. Because you could have stage 4 endometriosis and go through fertility treatment after fertility treatments, but they're not going to be successful. So, it's really recommended to remove even severe endometriosis, take down scar tissue, remove as much of it as possible prior to going through IVF, for example. Why? All right. So let me just do this. Oh no. Somehow I went to the, okay, here we go. All right. Common errors in management of endometriosis. So long-term treatment of symptoms like birth control pills for presumed endometriosis instead of laparoscopy, right? So I've heard patients tell me, I went to my OBGYN, she or he said, yes, you probably have endometriosis, you sort of have the classic symptoms, but what is the point of doing laparoscopy, right? We're just going to give you birth control pills anyways. Endometriosis can come back. So, just keep taking the pill and, hope that it controls the symptoms. The issue with that is that first, again, removing endometriosis will improve fertility rates. So what happens when you start trying to get pregnant? You're going to have to get off the pill. So even if that birth control pill controls the symptoms for now, it doesn't mean you're going to be fine when you're off. And actually, I've seen a lot of patients who were totally fine in their teens or in their 20s, then they stop the birth control pill to try to get pregnant, and all of a sudden they start having very painful periods, just progressively worsening periods. And that's how we sort of figure out that, oh my gosh, you probably have endometriosis. You probably had it all this time, but it was just masked by birth control pills. There's nothing wrong with managing mild endometriosis with birth control pills, but how do you know it's mild, right? Without doing laparoscopy. So that's the key. Multiple failed fertility treatments and no laparoscopy. So right? You could have severe endometriosis and have unsuccessful fertility treatments, and you're spending a lot of time, a lot of money, sort of a lot of emotions and anxiety, and not realizing you have advanced endometriosis. And then, conservative management for growing endometriosis cyst instead of removal, that's an issue. I see that all the time. So, yeah, you have an endometrioma, so we're just going to follow you. Let's keep getting ultrasounds every, 3 to 6 months. And then endometrioma keeps getting larger and larger. And then, okay, now it's so big, let's do surgery and take out your entire ovary. So, and that could have been prevented had we surgically intervened sooner. So, delay in care, it's a problem, with a lot of probably in medicine altogether, but in GYN, we see it a lot with fibroids, we see it a lot with endometriosis, and you have to, I think, be your own advocate, right? I always say this, don't delay. If you're in pain, go find somebody who will sort of listen to you. If you're have infertility, and again, you're going through fertility treatments and nothing is working, try to seek a second opinion. All right, I'm gonna go to some questions. So I think I answered the first one. Can pain from large intestine be related to endometriosis? So that answer is yes. How is bowel endometriosis diagnosed? Again, laparoscopy, right? And the symptoms can be severe constipation. It could be pain with bowel movements, especially worse during periods. Both small and large bowel examined during laparoscopy, yes. So the small intestine is extremely, extremely long. So you're not gonna be examining every inch of the small intestine during laparoscopy. But the large bowel is examined, and the most common location is down near the rectum where the uterus is located, and it's definitely fully examined. Adenomyosis does prevent fertility, or it can prevent pregnancy. It can make it also more difficult to get pregnant, even with fertility treatments. Can abnormal bleeding be a symptom of adenomyosis? Yes, for sure. Is the procedure in and out? What is the recovery period? Yeah, so that's a great question that I didn't answer. So the laparoscopy, it's outpatient. So you go home the same day. Procedure typically takes about an hour, can be less. At the same time as we do the laparoscopy, we also do cystoscopy, which is checking inside the bladder to check for inflammation and any sign of interstitial cystitis. We also check inside the uterine cavity, especially if someone has abnormal bleeding. So that takes typically less than an hour. If there's extensive endometriosis, then the surgery may take longer because we're trying to cut out all those lesions. Recovery period is about 3 to 5 days, again, depending on how extensive or mild endometriosis was. But typically most patients, by the end of the week, they feel fine. Another question, what about the recent research regarding bacterial genesis of endometriosis? Any novel treatments utilizing antimicrobials in the way of symptom management? I don't know of any antimicrobial treatment of endometriosis. Again, there's treating the symptoms versus treating the actual disease. The only thing that we know of to treat the actual disease is surgery with excision. Medication wise, it's really only the medications that block the estrogen production. And so those are sort of temporary measures, but surgery is the best thing to do first line. So if you do the laparoscopy, again, you figure out how extensive endometriosis is, how many lesions there are, right? And if all of it can be excised, that's a much better approach than having someone for 6 months or a year on anti-estrogen medications with a lot of side effects. So, all right. So do we have any other questions? Somehow we got through this very quickly. All right. Yeah.
No, I think we covered all the questions overall, and I think I also wanted to mention, I know some of the questions that you just had, like the method, like the methodology of it, and whether or not it is in and out. And I would recommend, I'm gonna go ahead and share it in this chat box, but there is a video, it's about 3 minutes of Dr. D kind of demonstrating hysterectomy that actually kind of shows the technique that's used, and she does a very good job of kind of demonstrating, even though a person is coming to us for like a fibroids, how we would also find adenomyosis and endometriosis in there. So that's a video that I recommend that I'll share over there in the chat box. And we have a question, what causes these conditions? I think we covered it at the beginning, Dr. D, right? Like what causes adenomyosis or
Yeah, I
endometriosis?
mean, we don't know what causes endometriosis. They're different theories, but we don't know how these abnormal cells really end up outside of the uterus, right? So the uterine lining, which is called endometrium, and that's where that word endometriosis comes from. So endometrium is a lining inside the uterine cavity. So, so this is the uterus, the lining in here. So that endometrial tissue normal endometrial tissue can only grow in that location. All right, so you can't have that endometrial tissue grow outside of the uterus. It wouldn't survive. So if I took a piece of endometrial tissue and just stuck it inside the pelvis, it's not going to attach and start growing. So it's abnormal. So there's some type of, we don't know, mutation or something happens. So it's an abnormal endometrium-like tissue that is able to grow outside of the uterus and implant on surrounding structures. Also, another thing I didn't mention is that in some cases, women who've had C-sections, they can have an implant of endometriosis growing in the C-section scar. So it would be in the, in the bikini line. So if you're someone who's had one C-section or maybe multiple C-section and have pain or even a lump that you feel in the abdominal wall that's sort of near the C-section scar, that could be endometriosis. Also, it could be in the belly button incision from prior surgery. So remember that abnormal tissue can implant in other structures. But as far as the cause, do we truly know how it got there? No, and we don't know why some patients have symptoms and why some don't. So there's in terms of likelihood of getting ovarian or uterine cancer when you have endometriosis. So there is a type of ovarian cancer that is more prevalent in women with endometriosis, but not to say that they're at higher risk. So there's clear cell carcinoma of the ovary. So it's a specific type of ovarian cancer that is seen more frequently in endometriosis patients, but that's not saying that endometriosis patients are at higher risk for ovarian cancer. Uterine cancer, typically we see it more often in postmenopausal patients that are overweight because of the estrogen, the excess estrogen that's not coming from the ovaries, but coming from fatty tissue. Or it could have a genetic component as well. So there's different components to cancers typically.
Does menopause help decrease endometriosis?
Yes, so because we know that endometriosis is estrogen dependent condition, right? So we don't know, again, what causes it exactly, but we know that you have to have estrogen for it to sort of survive, right? So if you have someone who is postmenopausal, that means the ovaries are no longer producing any sort of, good amount of estrogen. It might be very small, tiny amounts, but nothing enough to stimulate endometriosis. But if you have someone who is after menopause and overweight, that may be enough to stimulate existing endometriosis. Do you ever do the procedure a second time? Yes, absolutely. It could be even more than second time because endometriosis does come back, right? Because again, it's estrogen dependent. So as long as the ovaries are functioning, endometriosis can grow back. When, at which point do we do a second procedure? It really depends on whether, what are their symptoms, right? Are there symptoms? So let's say we do surgery, symptoms greatly improve, then over time, symptoms come back. That's when we might consider doing another surgery. If we did surgery and there was no improvement of symptoms, it really wouldn't make sense to then do another surgery because the first surgery didn't really help at all. So at that point, we try to find either a different cause of of pain, maybe look for adenomyosis. So yeah, but yeah, second procedure. I've seen patients that have had numerous surgeries for endometriosis, And when does it end? It really depends of different factors, but one is definitely fertility, right? If this is someone who doesn't desire fertility and have very severe endometriosis, then we proceed with the removal of the uterus and ovaries. Let's see. No, you're very welcome, Nilüfer. Patient successfully having children post laparoscopic treatment. Yes, actually, very recently, there was a patient who had that I found out she delivered because her OBGYN sent her like delivery C-section note. But I did her surgery in 2020 for fibroids. And at the time of the fibroid surgery, she was found to have pretty significant endometriosis, a lot of scarring near the fallopian tubes, near the ovaries. So in my note, I said she has stage 4 endometriosis and recommended that she see a fertility doctor to proceed with IVF. Okay. And she actually did get pregnant. But again, the key with 3 and 4 endometriosis is that first you do the surgery, right? You remove as much of endometriosis as possible. And keeping in mind, you could have endometriosis in the fallopian tubes, there could be endometriosis in the uterus, and obviously we're not removing those structures. So that's why I said as much as possible, realizing that not all endometriosis may be removed because we're trying to preserve fertility. And then after that, you would send the patient for fertility treatments because that's what's going to get a healthy egg. So you're sort of bypassing a lot of the inflammation issue. You're getting the egg instead of relying on spontaneous ovulation. You're putting you having the egg and the sperm form an embryo, right? You're bypassing some of the other issues with endometriosis, and then you're putting it directly into the uterus, and hopefully removing the endometriosis during the surgery will help improve the rate of implantation. But yeah, there are definitely patients getting pregnant with stage 3 and 4. We just have to, it's not going to be spontaneous. I mean, has there ever been a spontaneous pregnancy with 3 and 4 endometriosis? I'm sure there has been, but a lot of times there isn't. So we have to do something about it, right? Do the surgery and then do fertility treatments to achieve pregnancy. Yes, so, but with stage, that's 3 and 4, right? So we say surgery first, then fertility treatments more likely. With mild endometriosis, a lot of patients get pregnant spontaneously after removing endometriosis. And that's one of the benefits of doing endometriosis surgery, is that you're really improving fertility. So, and you're improving the rate of spontaneous pregnancy when removing endometriosis, and then of course fibroids.
Oh yeah, just so for people who can't see the question, Dr. D just answered, do you have an example of a patient getting pregnant spontaneously after getting endometriosis? I know that some people can, so it might be confusing there.
Yeah. Sorry, let me make sure I read the question. So next question is, do the skin scars go away? Also, can their surgery be done vaginally and not through a belly button? So you cannot do surgery vaginally, because, so here's a picture here. Hopefully I'm still sharing the screen. Yes. So if you go through the vagina, all you're going to get to is the uterus. You cannot get to the outside of the uterus going through the vagina. There's just no channel there. So that's why we go through the belly. So around here, we look inside and we're seeing all of this, right? If you go through the vagina, no, all you see is the uterus. You can go inside the uterine cavity, but then there's a dead end because there's a uterus there. And then do the skin scars go away? Yeah, they fade. They become very faint. So the picture of the scars that I showed you somewhere, that's just immediately after the surgery. So like we take out these, we call them trocars, and we sew, just put one stitch in each incision, and here they are. So they're fresh. So they do fade with time. All right, next question. If a patient has been diagnosed with multiple endometriomas on both ovaries via MRI and ultrasound, does that automatically correlate with stage 3 and 4 endometriosis? So that's a common question as well. Sometimes you can have endometriomas and not have endometriosis anywhere else. And that, of course, would be ideal. But again, you really would not know this without doing surgery. But most of the time, when you have bilateral endometriomas, which means endometriomas to both ovaries, you're going to have advanced disease, stage 3 or 4 disease. But it, again, you have to do laparoscopy automatically anyway. So if you have bilateral endometriomas, you do the laparoscopy, right? Because the goal is to prevent these cysts from growing larger and completely destroying the ovaries. So you go in, you take out the endometriomas, and then look around. A lot of times these endometriomas are stuck, the ovaries are stuck to the rectum, to all the surrounding structures. So typically it does indicate advanced disease.
So Dr. D, we talked about laparoscopy and being the best way of just kind of determining if someone has adenomyosis or endometriosis. Do patients have to request for that procedure, or is it a traditional way that your traditional OBGYNs would recommend that as a way of diagnosing these conditions? Or do patients have to actually actively ask for
So going back to, like, generalists versus specialists, and how, it takes years for a patient to be diagnosed with endometriosis. Part of it is because their, general OBGYN, or it could be their primary care, may be giving them birth control pills rather than saying you need a laparoscopy. So yes, a lot of times patients have to ask. I mean, does it mean that, okay, last week my period was painful, I need to do laparoscopy next week? No, I mean, if this is something that's ongoing, right? And especially if whatever you're doing is not controlling your pain. If you took birth control pills and your periods are much better and everything is great, you're not trying to get pregnant right now, no, you don't need to do anything. But again, if you're concerned about fertility, if you're not able to conceive after a year of trying, and if you're after the age of 30, it should be 6 months. If you tried 6 months and nothing happened, next step would be fertility evaluation. So if you're trying to get pregnant, you can't. If you have significant symptoms, laparoscopy is something you really should strongly consider to find out what is going on, so that you can address it appropriately. And but adenomyosis, just to correct you, adenomyosis is not always diagnosed by laparoscopy, because when you do laparoscopy, you can't see inside the uterus. So because laparoscopy, we're kind of on the outside here. See, I can see all this stuff, like all this bad stuff, but I really cannot see it unless I cut into the uterus. So if I'm taking out fibroids, I may find adenomyosis at the time of the surgery because I'm actually cutting into the uterus. But by just looking on the outside, you really don't know for sure if there is adenomyosis in this uterus or not. There probably is, just based on how extensive everything is, but not necessarily. So for that, we do an MRI.
All right, we still have about 10 minutes. So we have a lot of you still with us. So you can go ahead, if you have a question, you can just jot it down in the chat box or in the Q&A. Either or would work. I would also just mention that before you leave, I have shared a link to an evaluation form. So go ahead and please take a moment to complete that eval. It's very simple, shouldn't take more than a minute or so. And just in terms of like last minute things, as you think about your questions, is that as I said, for those of you who joined a little bit late, I'm going to send the resources that we talked about today, a link to our website, If you want to schedule a consultation, I'll also send that link via the follow-up, but I would also put it down here in the chat box to make it convenient for you. So sharing it right now.
Sorry,
The PowerPoint presentation and recording would also be available to you by the end of the week. We're thinking about holding in-person programs, and for those of you, I've seen a couple of you here who are healthcare providers. So we are also planning to have CEU events in the coming future. So we have a lot coming up to be excited about in terms of education. So be in the lookout for those in-person programs, CEU programs. And then if you want to refer back to a lot of these Ask the Expert series webinars, we have created a whole entire archive in our YouTube channel. So you can go back. We have done a whole full session on fibroids, ovarian cysts. And actually, we've done also a deep dive into some of the treatment options that Dr. D talked about today, the dual portal, the LAM procedure. So if you need to refer back to those, you could also do so by visiting our website. I don't see any questions coming in, so I'm gonna go ahead, and today would be one of those where we're gonna give you 9 minutes back to you. Yes, Dr. D, go ahead.
Before you wrap it up,
Wrap
I just wanted to show some pictures and maybe stuff, people will come up with additional questions, but most people like to see pictures of stuff. So, but this is an example of mild endometriosis, and that's another reason why you want to have a specialist involved in your care, in your surgical care, because endometriosis can look very different. So here you have these tiny little spots of endometriosis, very subtle. And then here you have this gray spot, which is very obvious. But then you have this other spot here, which is not as obvious, but both of these are endometriosis. There's another spot back here. And another important thing to do is that if you've had surgery, if you've had laparoscopy for endometriosis, but you're not sure if you had excision or ablation, is obviously to get the operative note and then to get the pathology report as well, right? Because everything that we remove or excise, we send to pathology. So if you had multiple areas of endometriosis, but there's only one, specimen, let's say bladder biopsy on the pathology list and nothing else, probably that one implant was taken out, but the rest was burned, something like that. This is I think I had that picture. So this is kind of a classic endometriosis lesion. So it's pretty thick, right? So this is going to be more consistent with stage 2, but still overall not very severe. This is not severe, but this is another endometriosis with scarring, but it's clear lesions, and kind of this shiny layer, which is the peritoneum, is sort of pulled up together, bunched up. So here's the 2 lesions here. So this is more advanced. You have all these, not smooth lining like here, because this and this is the same area. So you have very smooth, shiny versus here. This is all due to endometriosis. And then this picture I already showed, but this is severe endometriosis. This is all severe endometriosis. There's pockets of endometriosis in here. And then with excision, we're just, again, cutting out the abnormal area and then just stripping that lining off and cutting out here. Endometrioma. This is an endometrioma being peeled away from the normal ovarian tissue. So the ovary is actually back here. Let's see, I think that's it. I don't have any other. Oh, well, so that's another good question. Is that the surgery via robot, robotic versus dual port. So incisions wise, so with robotic surgery, typically there are more incisions. Each incision is larger. Also, the location of the incisions is different. So in terms of cosmesis, just cosmesis alone, with the dual port, 2-port, it's a much better surgery cosmetically. in terms of the effectiveness of the surgery, it depends who's doing it, right? Can you do really bad surgery robotically? Yes. Can you do really bad surgery using 2 ports? Yes. So it's the operator, right? So if the surgeon is very skilled, you're going to have good excision even using the robot, but you're going to have more and larger incisions. Were you going to say something?
I was gonna ask, in relation to like late stages of endometriosis, if someone
Yeah.
has like stage 4, a patient
Yeah.
comes to you, they
Yeah.
have stage 4 and they are trying to get pregnant, and so they're doing IVF. Are there certain things you take into consideration when you're providing consultation for surgery or such, for like example, age or things of that nature when you're doing consultation?
Yes, absolutely. So with stage 4 endometriosis, so if we know that this patient has stage 4 endometriosis, I'm assuming they've already had laparoscopy. And then the question is, how recent was this laparoscopy? So the laparoscopy was, 10 years ago. Then they definitely need a repeat laparoscopy to find out, what's going on now. Another thing is, because all of these things, unless we have pictures, so a lot of times when patients come to me and they've had a laparoscopy in the past and they just sort of tell me, okay, I was told I have stage 4 endometriosis, but I really don't have any pictures. It's all subjective, because somebody might say it's stage 4, and I'm like, well, okay, maybe it's stage 4 theoretically because it meets all the criteria, but it really doesn't look that bad. It doesn't look like this or like this. So in those 2 scenarios, one patient is going to have much better fertility outcome than the other. So there's, I guess what I'm saying, there's variations within the severe category, right? There's severe and then there's like really horrible. So what do I tell the patients? I mean, typically, yeah. So if we do laparoscopy, right, to look back and we confirm, yes, this looks really terrible, take down as much as scar tissue as possible, then you move forward with fertility. And the age of the patient absolutely has everything to do with success, right? So if I have someone who has mild endometriosis but who is 45 years old, pregnancy is unlikely to happen spontaneously or even with fertility treatments, unless we're talking about a donor egg. The donor egg is using an egg from a donor, right? Because it sort of bypasses the age issue. But there definitely, after the age of 40, there's significant decline in fertility. And then after the age of 45 or older, it's extremely, extremely low. So going to fertility specialists and finding someone who will do IVF at the age of 45 with their own eggs and spending a lot of money, we typically don't recommend, because it's just highly unlikely to happen. But as a patient, you have a choice, right? As long as you understand, if you're okay with, let's say, a less than 1% chance, but spending, 20, 30, $50,000, then, you do it. But then there's a whole ethical issue that comes into play from the doctor who is willing to take your money for such a low outcome. So you have to just decide for yourself. But typically, yes, in the older patients, we recommend a donor egg. And sometimes, unfortunately, because endometriosis affects the ovaries, affects the ovarian function, even in younger patients who otherwise should get pregnant spontaneously or with just IVF, they a lot of times are recommended to do donor egg because they just don't have any healthy eggs there. And again, that's another reason not to delay care. If you're not trying to get pregnant, but you have endometriosis that's pretty advanced, egg freezing is going to be an excellent way for you to preserve your ability to have sort of your own biological children. So You just have to keep all of these things in mind. You can't delay things or only look at things. Okay, I'm just going to worry about things right now. I'm not going to worry about things in the future, because that can have, sort of a negative effect. So
Well, thank you. So when in doubt, always don't delay care.
that's right.
Really seek out second opinion. I know you reiterated that all throughout, but definitely seek out second opinion. Don't delay care, and be your own advocate if you're really struggling and you need help. So be your own health advocate. And I'm just going to mention here, Dr. D just talked about the consultation process, but it's part of that consultation is making sure that it's comprehensive and taking in all the the factors into consideration when having that discussion with patients. So if you need to schedule an appointment with us, I've again, like I said, I've left that link here. So we are part of that option, but this part of this webinar is part of our, like I said, educate, empower, so that you can make informed decisions. So really use some of those resources that we have in terms of educational tools to your own advantage. Look at them, go through them before even, reach out to us, or reach out to us as soon as possible also. So we're here, we're available, and we are right there at 1:00 right now. I want to thank Dr. D for always being a sport and taking the time to do these educational sessions with us. And go ahead and complete that evaluation form and be on the lookout for our upcoming programs. Thank you so much, everyone, for joining us and for sticking with us. We'll be in touch soon. All right.
Thank you.
Have a
Bye, everybody.